Pharmacology. This is part 1 of 2. This one is how to give medication safely. I'm going to go over the 7 rights of safe medication administration. So it's right drug, right dose, right time, right route, right patient, right reason, and right documentation. It used to be just 5, but it's expanded to include some things that I think are important. The 7 rights. First one we're going to discuss is right drug. Check all the orders, labels, and confirm that the drug is appropriate for this client. Right dose. Is the dose appropriate for the drug, age, size, and patient condition? Right time and follow the agency's policy. Right route. Follow medication order and knowledge of appropriate routes for specific drugs. Right patient. Always identify the patient 2 ways. Patient's room number should not be one of the options, so it should be, as we had discussed previously, the medical record number or patient number, the social security number, the date of birth, the name. Right reason requires knowledge of a medication, knowledge of a patient. Question appropriateness and order if it doesn't make sense. Right documentation. This is very important for those people coming after you to know what you've done and what you gave the patient. Follow agency policy and procedure for immediate documentation. Time, route, response. So for right documentation, remember the 5 W's when documenting medication administration. When, why, what, where, and was. Was the medication tolerated or helpful to the patient? Medication documentation. First, make sure you have the right chart, or if you are on the computer and you have electronic health record, make sure you are in the right chart. Never chart a drug before it's administered. If you do that, it's really a medication error. You may go in there and the patient may refuse. Documenting includes name of drug, dosage, route, and time. Record location when giving parenteral medications, and follow agency policy if a medication was not given. Documents client response to the medication. You give a pain medication, you take the pain scale prior to. You give the medication, you come back, and you take the pain scale after. Preventing medication errors. You need to minimize verbal and telephone orders. Have the physician write it or enter it in the computer. Refrain from attempting to decipher eligible written orders. If you can't read it, ask for clarification. Always adhere to the 7 rights. Read the label 3 times, checking against the medication administration record, and listen to the patient. If they say, I've never been on that and I shouldn't be on that, you should listen to them. Double check with literature if in doubt about an order. So minimize interruptions while processing and preparing medications. That's very important. Many errors are done because of distraction. And do not agree to give medication in an area where you are not experienced or unfamiliar. Nursing process and medication administration. So the nursing process relates to this. So the first part is assessment. Medication history, allergies, ability to take med in the form provided, and diagnosis. Is this the right drug, dose, patient, etc.? Planning. How will the drug be given? Implementation, correct route, need for standard precautions, and evaluation. Was the medication effective? So the nursing process relates to giving medications. Patient assessment and medication administration. You need to assess patient variables that might influence drug therapy, assess drug history prior to the start of a new drug, assess patient's response to the medication, and assess physical parameters prior to administration, apical pulse, BP, respirations. Some medications, it's essential that you do this, such as digoxin. You would need to take an apical pulse prior to giving to make sure that it's not below 60, as an example. National patient safety goals related to medication administration. As we talked about, use at least 2 patient identifiers just prior to medication administration, and verify verbal and telephone orders by verbally reading back to the order to the licensed independent practitioner route. So verbal order with readback, or telephone order with readback. National patient safety goals related to medication administration. Continue. Take actions to prevent errors involving sound-alike or look-alike drugs. So often a facility we'll have these posted right by where the medications are given, medication room or the automatic dispenser like Pyxis. You need to label all medication containers both on and off the sterile field. So this applies to syringes that are drawn up and not given immediately. Follow agency policy concerning a comparison of the patient's currently prescribed medications with those just ordered during the current visit. Medication reconciliation. So some of the laws affecting medication administration: the Controlled Substance Act, also known as the Comprehensive Drug Abuse Prevention and Control Act, response to growing misuse of drugs. Medication orders should be written clearly, legibly, and easy to understand language. Should be clarified if unclear. Check with your direct supervisor. Should not include blanket summary statements such as resume all pre-op orders. Essential parts of a medication order: for those people who are still in paper chart, for electronic health record, this is pretty much taken care of for you, as a physician cannot continue unless they've done all this. But it's patient's full name, date and time of order, name of medication to be administered, dosage, frequency, route, number of doses or days medication is to be given, and signature of the ordering physician. Do not use abbreviations. Some of the more common ones that we have here: U for unit, IU for international unit, QD, QOD, trailing 0, MS, MSO4, MGSO4, greater than, less than, other abbreviations for drug names, CC for cubic centimeters, and UG for microgram are the ones that are quite common. Sources for locating drug information: physician's desk reference, national formulary, hospital formulary, you can call the pharmacist, drug reference books, pharmacology textbooks, and computer-based indexes. So let's discuss drug misuse. Drug misuse: improper use of any medication which leads to acute or chronic toxicity. Drug abuse: inappropriate intake of a substance. And drug dependence: it's a person's reliance on or need to take a substance. That includes both physiological dependence, which is biochemical changes in body tissue, especially the nervous system, which leads to a requirement by the tissues to function normally. Psychological dependence: emotional reliance to maintain a sense of well-being. Pharmacokinetics, that is what the body does to the drug, includes the absorption, how the drug is given and in what form, the distribution, how much of the drug is given, the blood flow, metabolism or biotransformation, which is based on liver function, age, nutritional status, and the excretion, which is affected by liver function and renal function. So drug effects: onset, time it takes for a therapeutic response; the peak, time it takes for a maximum therapeutic response; and duration of action, length of time that drug is concentrated, that drug concentration is sufficient for a therapeutic response. Drug half-life: the time it takes for half of the original amount of the drug to be removed from the body. Useful in determining the amount of drug and blood level in relation to the amount removed by elimination. Pharmacodynamics: how the drug affects the body. Biological, chemical, and physiological actions of a drug within the body. Drugs can promote, block, or turn on or off responses. They cannot create a new response. Loading dose. Loading dose is the one that is larger than the standard dose. It is given at the beginning of the drug therapy to raise the blood levels quickly. It is used when the desired therapeutic response is required more quickly than be achieved by the standard dose. Maintenance dose is a dose in which is one that continues to keep the drug in the desired therapeutic range. It is used after the loading dose, and for many drugs, patients receive the maintenance dose both at the start of therapy and throughout therapy. Many drugs do not have a loading dose. Therapeutic index relates to a drug's margin of safety, the ratio of effective dose to the lethal dose. Tolerance means that a larger dose is needed to bring about the same response, such as narcotics. Adverse effect: any non-therapeutic response to a drug therapy. Consequences that may be minor or significant. drug interactions. Action of one drug on a second drug or other element creating one or more of the following: increased or decreased therapeutic effect of either or both drugs, a new effect, an increase in the incidence of an adverse effect. Causes of drug interactions: GI absorption, enzyme induction, renal excretion, pharmacodynamic effects, patient care variables. Allergic reaction. Allergic reactions are altered physiological reaction to a drug that occurred because of a prior exposure to the drug stimulated an immune system to develop antibodies. Anaphylaxis is the most serious allergic reaction. Accumulation occurs when the dose exceeds the amount the body can eliminate through metabolism and excretion. It is called toxicity if tissue organ damage occurs, and factors contributing to accumulation are age and underlying disease. Toxicity, evaluating drug levels. When receiving certain medication, blood samples are drawn to maintain blood levels within a therapeutic margin. There's a peak where you draw a peak level 30 minutes after IV administration and 1 hour after IM administration, and there's a trough where you draw a level just before the next dose, sometimes before the third dose. When assessing for signs of toxicity, you would assess for ototoxicity, which is a common one, for balance and hearing. Ringing in the ears is a common complaint. Nephrotoxicity, intake and output, proteinuria. GI toxicity, diarrhea. And neurotoxicity, drowsiness or seizures. Patient teaching. To grant legal consent to treatment, patients must be informed about drug regimen. Assess patients' knowledge of the medication, provide information about the purpose of the drug, action and side effects, and teach how to self-administer drugs and incorporate into daily routines. Let's talk about route of administration. It depends on drug characteristics, desired response, and each route has its advantages and disadvantages. Oral route, simple and convenient, relatively inexpensive, can be used by most people. Disadvantages: it's slower drug actions, and its possible irritation of GI tract. Assess patient. Can they swallow the pill? Can you crush tablet if appropriate? Don't ever crush the enteric-coated or time-release capsules. And most of the time, crushed tablets can be mixed with food. Sublingual and buccal administration. It prevents destruction of the GI tract. It allows rapid absorption into the bloodstream. And sublingual tablets placed under the tongue, buccal tablets placed between upper and lower molars in the cheek area. Instruct patient to allow medication to dissolve and drink, and not drink until completely resolved. Topical administration primarily provides local effect. Clean off old medication, apply using an appropriate device. Special considerations for nitroglycerin and transdermal meds. Rectal administration, assess the patient, the GI function, and anal competence, make sure that there isn't any problem. Keep suppository in refrigerator until ready to administer. Place patient in left lateral position. Lubricate the suppository. Insert past the anal sphincter, and for animals, have them retained for 20 to 30 minutes for maximum effect. Inhalant administration, check vital signs. Have patient exhale deeply before activating dose. Have patient close lips around the mouthpiece without touching it, and use spacer device when needed. Nasal administration, have patient blow nose. Have patient keep head back, push up the tip of the nose, and place tip of administration device slightly inside the nose. May cause aspiration, so you need to be careful. Ophthalmic administration, if possible, use warm solution. Administer with patient supine or sitting up with head back. Have patient look up, place drop in conjunctival sac, and have patient blink to distribute the medication. Otic or ear administration, position patient with affected side up, straighten ear canal up and back. Adult, that's up and back, but children under 3, you pull it down and back. Warm the solution slightly. Mineral oil sometimes used in advance to soften wax prior to fleshing, and instill drops into the ear canal. Parenteral route, refer to any route other than gastrointestinal, commonly subcutaneous, intramuscular, or IV injections. Must be prepared, packaged, and administered to maintain sterility. Multi-dose vials are generally discouraged. Single-dose vials, even though more expensive, are the preferred route. For parenteral administration, use only sterile needles and syringes. Needles and syringes are available in various gauges and volumes. The larger the syringe, the lower the injection pressure. For volumes less than 1, use TB or 1 ml syringe. Use an insulin syringe for insulin. Equipment for injections. Choice of needle gauge depends upon route of administration, viscosity of the solution, size of the client. Usually 25 gauge and 5/8 inch needles subcutaneous and intradermal, 20 or 22 gauge, 1.5 inch for IM. Medications in ampules or vials. Ampules are sealed glass containers. The top is broken. Medication is removed by needle and syringe, and it is preferred to use a filtered needle to prevent the intake of any glass. Unused portions must be discarded. And vial with powdered form, follow directions to dilute with sterile water or normal saline. Subcutaneous administration. Injection of drugs under the skin. Used for small volumes. You can't put more than 1 ml. Absorption is slower. Drugs that are irritating to tissues cannot be given subcutaneous. Common sites: upper arms, abdomen, thighs. Use a 25 to 27 gauge needle, which is the smaller needles. Consider tissue and gather tissue in opposition and pull it up slightly. Insert needle at a 45 or 90-degree angle using a pushing action. Do not aspirate, and if any anti-blood clotting agent, do not massage site. Intradermal medication. Use a 26 to 27, even smaller gauge needle. Apply traction to the skin near the site. Place needle with bevel upward. Inject small wheel, which is a small amount of medication at the site, and withdraw a needle. Do not massage, and the maximum volume is 0.1. Intramuscular administration involves injection of drugs into muscle. Absorption is more rapid due to blood supply, and incorrect injection techniques may damage blood vessels and nerves, so be very careful. There's dorsogluteal, ventrogluteal, deltoid, and vastus lateralis. Intramuscular administration. Use a 21 to 22 gauge needle. Insert at 90-degree angle. Max volume is 5 ml. Usually doses, though, of 1 to 3. Z-track for solutions that are irritating to the tissues. Pull skin away from the site to displace tissue. Inject medication and let go. And then it kind of seals that medication in there. And do not massage after injection. Intravenous or IV administration involves injection of drugs directly into the bloodstream. Drugs act rapidly, administered through established IV line or direct injection into the vein, used for intermittent or continuous infusions. Advantages: client comfort, easy access for nurses. Disadvantages: time and skill required for venipuncture, difficulty in maintaining an IV site, and greater potential for adverse reactions. Also, possible complications of IV therapy. You would notice them, and they would happen sooner and stronger. So, assess IV insertion site. Look for pain, redness, bleeding, swelling, dressing, dry and intact. This is a picture of somebody with extremely good veins. You probably not find that too often in the hospital, but in this case, it looks like that individual will be very easy to draw blood from or to start an IV. Nursing care with IV medications. Use standard precautions. Wipe port with alcohol before accessing. Strict sterile technique when preparing medication. And new guidelines require IV securing device, transparent dressing, or sterile tape to secure catheter to the patient. When discontinuing IV therapy on a client on anticoagulants, prolonged pressure may be required, as would be expected. Document as per policy. Intravenous piggyback. IV piggyback is a small volume of medication that is attached or piggybacked onto the port end of existing IV. Alcohol the port before attaching the piggyback tubing. Intermittent IV therapy. Patients may have a saline lock, or what was referred to as a heparin lock in the past, without a primary IV running through it, used just for intermittent injections. Flush before and after medication with normal saline. IV push. The medication is pushed into the port by the nurse. Before pushing, the nurse must know if the medication is compatible with the existing IV fluid, the rate that the push should be given, usually in minutes. Intravenous administration equipment. Pump, deliver at milliliters per hour. Most pumps deliver to the 10th place, 85.5 mLs per hour. Check IV site before connecting the pump. Set rate according to physician's order and check for kinks or obstructions frequently. Calculation of doses. So we will go through a fairly simple one. Dose on hand, let's say you had a 250 milligram tablet. The quantity on hand was 1 tablet equals 250 milligrams. The desired dose equals 500 milligrams. If you did a ratio on this kind of medication administration sample, it would be 250 over 1, because you have 250 milligrams in 1 tablet equals 500 in X. You want to give 500, but you don't know how many tablets. If you cross multiply, 250X equals 500, X equals 2. So this is a very easy one, I understand that, but they're not always this easy, and the dosing may be quite complicated. You can still use this to figure this kind of question out. Practice the following. So dose on hand 250, quantity on hand is 1 capsule, and in 1 capsule is 250 milligrams. Desired dose is 0.5 grams. Convert 0.5 grams to milligrams, which is 1 gram is 1,000 milligrams, so 0.5 grams equals 500 milligrams. 250 over 1 equals 500 over X, which is the unknown. 500 divided by 250, 2. The answer is 2 tablets. Dose on hand, 10,000 units. Quantity on hand, 10,000 units per 1 ml. Desired dose, 5,000 units. 5,000 units equals X. 10,000 units equals 1. 5,000 divided by 10,000, or 1/2, or 0.5. The answer is 0.5 ml. Practice the following dose based on weight. Medication over Lovenox, 1 milligrams per kilogram twice a day. Dose quantity on hand, 80 milligrams per ml. Patient's weight, 154 pounds. For pounds to kilograms, because the dosing was in kilograms, 154 divided by 2.2 is 70 kilos. 1 milligram times 70 kilos equals 70 milligrams. Cross multiply and divide. 80 milligrams over 1 and 70 milligrams over X. 70 divided by 80 equals 0.8. Answer is 0.8 mLs. That'll conclude part 1